Hello everyone, this is Dr. Sam and today we will discuss image appearances of liver. The first two images are normal appearances of the liver. This is the left lobe in sagittal view and this is the right lobe. Right here is the kidney and the liver is having smooth echo texture. In transverse view of the liver, we can see the blood vessels. The portal vein will have hyperechoic walls, and right here is the inferior vena cava in cross section, and over here these are the hepatic veins. They will not have hyperechoic walls. Here we have the caudate lobe in sagittal view. It should measure 35 millimeters in AP diameter, and this line here is the ligamentum venosum, and over here is the hypertrophy of caudate lobe. You can see it is enlarged. It occurs in conditions such as liver cirrhosis. A simple hepatic cyst will be round, anechoic, and have posterior acoustic enhancement. This cyst is present in the left lobe and this is a sagittal view. Here is a transverse view of a simple hepatic cyst in the right lobe of the liver. A hydated cyst will have septations. These walls are septations and they can have echogenic material as well. And they can also have daughter cysts, which means that there could be a cyst such as this one, this cyst within this hydated cyst. A calcified hydated cyst will have hyperechoic calcified rim, and this will lead to posterior shadowing, and internal septations may also be noticed. An abscess can have variable appearances. Mostly it is hypoechoic, but depending on its density it can be hyperechoic, and also it is heterogeneous. But the main feature is that it will have no flow on Doppler, which can distinguish it from other masses. An abscess in the right lobe of liver. This is the transverse view. It is mostly hypoechoic and has heterogeneous areas as well. And when we apply Doppler, it will not have any flow. Hemangiomas are benign liver masses. They are mostly hyperechoic, well defined, and they can be more than one. And they will not have any posterior shadowing. Here you can see one mass here and another mass over here. Here is a sagittal view of the liver showing a hemangioma right here, and when we apply Doppler it will not have any central flow. Focal nodular hyperplasia is another benign lesion of the liver. This can have variable appearance. It can be isoechoic, it may also be hypoechoic. It has a main feature on Doppler, that is the spoke wheel appearance. When we apply Doppler, we will have this type of flow which resembles a spoke wheel, and this is a feature of focal nodular hyperplasia. A hepatic adenoma is a solitary well-defined mass. It has variable appearance, but mostly it is hypoechoic. But we cannot confirm these lesions on ultrasound. We need to perform a CT scan. A hepatocellular carcinoma is a malignant lesion of the liver. It has a hypoechoic appearance and larger masses may have a heterogeneous appearance, but we need to perform a CT scan to have proper diagnosis. This mass is larger than the previous one and it has somewhat of a heterogeneous appearance. Metastases in the liver are well defined and rounded. They will have a hypoechoic halo. The outer region is hypoechoic and will have a hyperechoic center. This type of appearance is called a target sign or the bullseye appearance. It is very specific to metastatic lesions. This image shows multiple metastatic lesions in the liver, showing us again the target sign. Some metastatic lesions can have cystic components as well. Over here we have the hypoechoic halo and a hyperechoic inner region followed by a cystic area in this metastatic lesion. This image shows multiple metastatic lesions along with a fatty liver. Now we move on to fatty liver or hepatic steatosis, starting with grade 1, the mildest form of fatty liver. The liver will appear hyperechoic, more hyperechoic as compared to the kidney, but we can see the diaphragm normally, and we can also see the hyperechoic walls of portal vein. In grade 2 steatosis, the echogenicity of the liver is increased and we cannot see the hyperechoic walls of portal vein. We cannot see that clearly, but we can still see the diaphragm clearly. So this is a feature of grade 2 steatosis. In grade 3 steatosis, there is no visualization of the diaphragm, and overall there is poor visualization of the liver structures such as the vessels. Cirrhosis of the liver is a serious condition in which the liver will be reduced in size and will have surface nodularity, which is the rough surface of the liver, and it will have coarse echo texture, which is also the rough echo texture of the liver, and it may also have ascites, which will be fluid surrounding the liver in the abdominal cavity. Here is another image of a cirrhotic liver showing us surface nodularity and a shrunken liver with coarse echo texture surrounded by ascitic fluid. Portal hypertension can occur due to cirrhosis. In this, the diameter of the portal vein will be more than 13 millimeters and it will have reduced flow in the intrahepatic portion of the portal vein. It can also have flow reversal on Doppler. Here you can see the blue color, which is suggesting the flow is moving in this direction away from the liver. This is a flow reversal. The viral hepatitis has one classic sign known as starry sky sign. It is also known as centrilobular pattern. You can see echogenic dots in the liver, which resembles a starry sky. Hello everyone, this is Dr. Sam, and today we will study gallbladder pathologies. The normal gallbladder has an anechoic lumen with hyperechoic walls, and here is the neck of the gallbladder, and over here is the fundus, and the central part is the body, and this is the transverse view of gallbladder. The Phrygian cap is a normal occurrence in the gallbladder in which the fundus will fold on itself. It is not a disease, but just an occurrence. A multiseptated gallbladder gives a honeycomb appearance, which looks like this. Multiple septations inside the gallbladder. They are asymptomatic, but they should not be ignored because they may lead to malignancy. This is the appearance of a contracted gallbladder. It occurs when the person has recently eaten, and the walls may appear thicker than normal, but as you can see, it is less than 3 millimeters. So it is a normal thickness of the gallbladder wall. Here is a transverse view of a contracted gallbladder. The wall is measuring 2.6 millimeters, so that is normal. Duplication of the gallbladder can occur. Here you can see two separate gallbladders in this image. In partial duplication of the gallbladder, the body and neck are common, but here you can notice one fundus over here and another fundus over here. Gallstones appear as hyperechoic structures inside the gallbladder, and they will produce posterior shadowing. In this image there are 4 gallstones, and each one is producing its own shadow posteriorly. This image shows 3 gallstones also producing posterior shadowing. The West sign stands for wall echo shadow sign. It occurs in a gallbladder that is completely filled with stones. The first layer that we see is the gallbladder wall. It is slightly hypoechoic, followed by a hyperechoic layer, and that layer is of the stones. And behind that, or below that, is the shadowing, posterior acoustic shadowing. Gallbladder sludge is the thickened form of bile. It has increased density, so that is why it is appearing hyperechoic without any posterior shadowing, and it is mobile. That is, when the patient shifts his position, the sludge will also change its position relatively. Here is a transverse image of the gallbladder showing sludge, which is hyperechoic due to thickening of bile. Acute cholecystitis is the inflammation of the gallbladder. In this, the first sign is the increase in wall thickness, which is more than 3 millimeters. In this transverse view, we can see a thickened gallbladder wall. And there can be presence of gallstones or sludge, and also the presence of pericholecystic fluid. In this image you can notice pericholecystic fluid over here, fluid outside the gallbladder, and the walls are also thicker, and also there is presence of sludge. Here is another image of acute cholecystitis in the longitudinal view. Another sign, known as sonographic Murphy's sign, is helpful in diagnosing cholecystitis. In this, the pressure is applied with the transducer while scanning the gallbladder, and while applying the pressure, the patient will feel pain and tenderness, and that is a positive Murphy's sign. Gangrenous cholecystitis is a more severe case. In this, there is disruption of the gallbladder wall. There are sloughed membranes. There can be wall ulceration as well. In this image, you can notice wall ulceration. This ulceration is a sign of gangrenous cholecystitis. Here is a longitudinal view showing wall ulcerations. You can see 3 of them here. In gallbladder perforation, there is a large defect in the gallbladder wall, which leads to leaking of the contents outside. And here you can see communicating pericholecystic fluid due to puncture of the gallbladder wall. In the longitudinal view, we can see it more clearly, the defect in the wall and the communicating pericholecystic fluid. This is a strong sign of gallbladder perforation. Polyps are masses attached to the gallbladder wall by a stalk. Here you can see the mass is attached to the wall, and this is also known as ball on the wall sign. Here you can see a polyp attached to the wall in this longitudinal view here in the fundal region. In this image you can see multiple polyps attached to the wall. Here you can also notice one stalk. Adenomyomatosis occurs when there is a herniation of the mucosal layer of the gallbladder wall into the muscular layer of the wall, and this can form sinuses or pockets. These sinuses are known as Rokitansky-Aschoff sinuses, and cholesterol crystals can get deposited here, which will give comet tail artifacts, and they look like this, and they also give bright reflections. Here is a transverse view of adenomyomatosis showing comet tail artifacts. In gallbladder carcinoma, we can see a hypoechoic and heterogeneous mass attached to the wall. This can also lead to increased thickness of the gallbladder wall, and it may be infiltrating into other structures such as the liver. Here is an image of wall thickening due to hepatitis. Here there is only wall thickening and no other feature is seen such as gallstones or sludge. There is extensive wall thickening in this image. Longitudinal view of the same case showing extensive wall thickening in hepatitis. Porcelain gallbladder presents as calcification of the gallbladder wall, and we will see hyperechoic gallbladder wall with posterior shadowing. Here is a transverse view showing hyperechoic walls with posterior shadowing. Hello everyone, this is Dr. Sam, and today we will study bile duct ultrasound. The main bile ducts that we will see are the hepatic ducts or intrahepatic bile ducts and the common bile duct. Here we can see the hepatic duct. It is anterior to the portal vein and is anechoic with hyperechoic walls. The right and left hepatic ducts join together to form the common hepatic duct. Then the cystic duct, which comes from the gallbladder, joins common hepatic duct to form common bile duct. Here is the CBD entering the pancreas. The hepatic duct measures less than 2 mm in diameter. The diameters of the common hepatic duct and common bile duct are variable, but a value of 7 mm has been used for normal values in recent years. And we see the hepatic artery in cross section here. After a cholecystectomy, that is gallbladder removal, the diameter will increase. After the age of 60, the diameter starts to increase by 1 mm every 10 years. Choledochal cysts are congenital dilatations of bile ducts. The most common type is fusiform dilation. It is a type 1 choledochal cyst. The common bile duct is dilated and it is open from both sides. This end leads to the pancreas. Here we have an image of a dilated common bile duct. The diameter will exceed 7 mm and there will be no blood flow seen on Doppler. This appearance is termed the double barrel sign. It is formed by the dilated duct which is anterior to the portal vein. Caroli disease is also congenital. There is multifocal cystic dilatation of the intrahepatic ducts. That means these bile ducts are dilated at multiple locations. It is a type 5 choledochal cyst. Another feature of Caroli disease is the incomplete intraductal hyperechoic bridging septa. Here is another image of Caroli disease with cystic dilatation of intrahepatic ducts. The central dot sign is formed by dilated bile duct surrounding the hepatic artery and portal vein. This dot is formed inside the bile duct by either the hepatic artery or portal vein. Intrahepatic biliary stones will appear hyperechoic with posterior shadowing. In this image, there are 4 stones within the hepatic bile ducts. In this image, we have a stone in the common bile duct. It has posterior acoustic shadowing. Merizzi syndrome refers to compression of the extrahepatic bile ducts due to stones either in the cystic duct or the gallbladder. Here we can see a stone in the cystic duct causing obstruction and also compressing the common hepatic duct. This led to dilated hepatic bile ducts. Hemophilia refers to blood clots in bile ducts. Usually it occurs after a biopsy in this area. It can also occur due to surgery, malignancy, cholecystitis, or any biliary trauma. Solid echoes will be seen in the bile ducts. The blood clots may be seen floating and moving in the bile duct. In acute hemorrhage, the bleeding is fresh and it may appear hypoechoic because the blood hasn't clotted yet. Blood may also be seen in the gallbladder. In pneumobilia, air is found in the bile ducts. They are seen as hyperechoic linear structures with posterior dirty shadowing. You will see a grayish shadow along with a ring down artifact. Cholangitis is the inflammation of the bile ducts. In acute cholangitis, which is also called ascending cholangitis, the common bile duct is dilated and the bile duct walls are also thickened. In this image, we can see a stone in the bile duct with posterior shadowing. causing inflammation. The bile duct is dilated. Here we can see thickened walls of the bile duct. In normal wall thickness, these echoes are not seen, but in thicker walls, we can see them inside the bile duct. Recurrent pyogenic cholangitis is a disease in which there are dilated bile ducts filled with stones and sludge. The stones will often have shadowing, but smaller stones may not have shadowing. It occurs in the setting of a bacterial biliary tract infection. In primary sclerosing cholangitis, there is irregular bile duct wall thickening and narrowing of the bile duct lumen. At this point, there is more wall thickening as compared to this area, so it is irregular. Ascariasis is a type of roundworm infection. These parasitic worms can enter the bile ducts through ampulla of Vater in duodenum. The worm will appear as a tube-shaped structure in the bile duct or as parallel hyperechoic lines. If it is seen moving, it can be very helpful in diagnosis. HIV cholangiopathy or AIDS cholangiopathy is seen in AIDS patients. Hyperechoic tissue is seen around the bile ducts. The bile duct walls are irregular, and also there is irregular bile duct wall narrowing. Cholangiocarcinoma refers to bile duct cancer. The first type is intraductal cholangiocarcinoma. A mass is seen in the bile duct. It can either be isoechoic or hyperechoic to liver. Bile duct is obstructed as well. Intrahepatic cholangiocarcinoma is the second type. It can come under liver cancers as well. There is a large heterogeneous mass involving both the bile duct and the liver. Hilar cholangiocarcinoma is also called Klatskin tumor. It is found in the hilar region of the liver as well as around common hepatic duct bifurcation. The mass is mostly hyperechoic but can sometimes be hypoechoic or isoechoic. In this image we can see both the right and left hepatic ducts, but they are not continuing to form the common hepatic duct because the mass has occupied this region. This is called non-union of right and left hepatic ducts, and this feature is helpful in diagnosing hilar cholangiocarcinoma. Hello everyone, this is Dr. Sam, and today we will discuss ultrasound appearances of pancreas. The pancreas is well appreciated in the transverse view. It is homogeneous and somewhat hyperechoic. Here is the liver, left lobe of liver. It is used as a window to scan the pancreas. And this curvilinear structure is the portal splenic confluence, where the splenic vein joins the portal vein. And here is the superior mesenteric artery, and these are the aorta and the inferior vena cava. And we can notice the head of the pancreas over here, and here is the body of the pancreas. Acute pancreatitis is the inflammation of the pancreas. In this we will see a heterogeneous appearance of the pancreas, and it will appear enlarged, and there will be peripancreatic fluid, some fluid outside the pancreas. Here you can see the pancreas is enlarged. If the diameter of the head exceeds 3 centimeters, and if the diameter of the body exceeds 2.5 centimeters, it is a sign of pancreatitis, and it has an overall heterogeneous appearance, and peripancreatic fluid is also noted here. In chronic pancreatitis, there is calcification of the pancreas, and it leads to these hyperechoic calcifications which produce shadowing. Here is another image of chronic pancreatitis showing smaller calcifications and also showing some comet tail artifacts. Chronic pancreatitis may lead to atrophy of pancreatic parenchyma. We do not see much of the parenchyma of the pancreas. We don't really see the body or the head as much as it should be. We also see a dilated pancreatic duct. The diameter of this pancreatic duct is definitely more than 3 millimeters. A pancreatic pseudocyst can occur after a pancreatic injury or after acute pancreatitis, and the cyst will contain pancreatic enzymes and it will arise from the pancreas. Here you can see it is connected to the pancreas. So most of these appearances are pseudocysts. This pseudocyst is much larger in size and it is connected to the pancreas, growing anteriorly to the pancreas. If the diameter of the pancreatic duct exceeds 3 millimeters, it is a dilated pancreatic duct. Although this image is of a pseudocyst, but we can see a normal pancreatic duct over here, whereas over here it is very much dilated. Here is another image of a dilated pancreatic duct. Just remember, when the diameter exceeds 3 millimeters, it is dilated. The pancreatic duct may also have stones. They will appear as hyperechoic and will give posterior shadowing along with a dilated pancreatic duct. A cystadenoma of the pancreas may have a unilocular or a multilocular appearance. These are the compartments inside the cyst. They can be either one or more than one. These compartments are called locules. They can be either one or more than one. A microcystic adenoma, as the name suggests, has small cystic components inside a hypoechoic mass. Here you can notice small cystic components inside a hypoechoic mass. Adenocarcinoma is a malignant lesion of the pancreas. Here it is occupying the head of the pancreas. It mostly has a hypoechoic appearance and can also lead to dilation of the pancreatic duct. Here is another image of adenocarcinoma, another lesion occupying the head of the pancreas. It is hypoechoic and also somewhat heterogeneous. Another mass occupying the head region of the pancreas. It is more heterogeneous, also somewhat hyperechoic. Another form of neoplastic lesions of the pancreas are insulinomas. They appear as hypoechoic masses. Over here, this mass resides in the body of the pancreas. Metastatic lesions in the pancreas will also give a hypoechoic appearance. Here is a metastatic lesion in the pancreas due to lung cancer. Pancreatic injury can lead to enlargement of the pancreas and also fluid collection, that is communicating with the pancreas due to injury. Hello everyone, this is Dr. Sam and today we will discuss ultrasound appearances of spleen. The spleen is an intraperitoneal organ that is crescentic in shape and has homogeneous echo texture. And the hilum is the region where the blood vessels enter and exit the spleen. The splenule, also known as accessory splenic tissue, can be found in the hilar region or even at the lower pole of the spleen. It is an accessory splenic tissue. It is not a pathology. It can occur in some patients and it will have an isoechoic appearance, similar appearance to the spleen. And on Doppler, it can have blood supply which can be noted. Here you can see two separate splenules. They can be more than one in some cases. Splenomegaly is an abnormal enlargement of the spleen. If the length exceeds 13 centimeters and the thickness exceeds 6 centimeters, then it is termed as splenomegaly. Here you can notice splenomegaly in transverse view. You can measure the thickness of the spleen in this view. If you notice a well-defined hyperechoic line passing through the spleen, it is a splenic cleft. It is also a normal occurrence. A splenic cyst is a cyst just like in other organs, a well-defined anechoic structure and will have enhancement. Sometimes the cysts can have calcified walls which will appear hyperechoic and have posterior shadowing, but it is a very rare occurrence. A complex cyst will have internal echoes and multiple septations. A hemangioma in the spleen will appear as a hyperechoic, well-defined lesion, and it is also homogeneous. Another image of a hemangioma in the transverse view appearing as a hyperechoic and homogeneous lesion. The appearance of lymphangioma consists of multiple cysts. Here you can see a lot of cysts inside the spleen. In this image you can see multiple cysts that are connected together, which means they have a common wall. This type of appearance can also be seen in a lymphangioma. Extramedullary hematopoiesis usually involves the whole spleen, but sometimes they can be focal. When they are focal, they present as hyperechoic masses without any internal flow on Doppler. An inflammatory pseudotumor can occur in the spleen as a large heterogeneous mass. It mimics the appearances of other tumors. It is a very rare lesion of the spleen. On applying color Doppler, we will notice hypervascularity in the mass. In the normal spleen, you can see it is not as much as it is in the inflammatory pseudotumor. A lymphoma is the most common malignancy of the spleen. It appears as a hyperechoic, solid, spherical mass inside the spleen. Lymphomas may sometimes involve the entire spleen, appearing as multiple hypoechoic areas spread throughout the splenic tissue. Metastatic lesions in the spleen will appear as target lesions, which include a hypoechoic halo and a hyperechoic center. Here is a transverse view showing multiple metastatic lesions appearing as hypoechoic halos with hyperechoic centers. Metastatic lesions can also have variable appearances depending on the type of primary cancer. In this case, it is from a metastatic melanoma. Here you can see solid areas as well as cystic components in this large mass, overall giving it a heterogeneous appearance. An abscess in the spleen will appear as a complex cyst with internal echoes, and the main distinguishing feature is that there will be no flow on color Doppler. Gamma-Gandhi bodies involve the entire spleen. They appear as scattered, bright, hyperechoic reflectors throughout the splenic tissue. Here you can notice these hyperechoic dots, and they are scattered throughout the spleen. Here is a transverse view showing Gamma-Gandhi bodies, hyperechoic bright dots, bright reflectors without any shadowing. Granuloma in a spleen can occur in the setting of mycobacterial infections and histoplasmosis. They appear as multiple hyperechoic calcifications scattered throughout the spleen. Another case of granulomatous infection on the spleen, presenting as multiple calcifications throughout the spleen. The appearance of sarcoidosis can mimic other types of appearances such as of lymphoma. That is why these need to be clinically correlated. They appear as hypoechoic nodules in the splenic tissue. The spleen is prone to injury in the setting of blunt trauma and often present with free fluid which is anechoic due to fresh blood, and it can also have heterogeneous or hypoechoic areas referring to hematomas. Here you can see a subcapsular hematoma in the setting of trauma to the spleen. It is filled with heterogeneous areas. Sometimes an elongated left lobe of the liver can reach the area of the spleen and can come in the field of view. This can mimic a hematoma. Here is the liver actually, it is not a hematoma, and we can distinguish it by using color Doppler. The liver will have internal flow, whereas the hematoma will not have any flow. Here is an image with color Doppler applied. You can see blood flow inside the liver. This type of condition is called pseudo-perisplenic fluid. Splenic infarcts appear as wedge-shaped lesions and also give a coarse appearance, coarse echo texture of the spleen. And when we apply Doppler, there will be absence of flow due to infarction. Here you can see splenic infarcts appearing as wedge-shaped regions inside the spleen. Splenic torsion will also give absence of flow on Doppler. It can also lead to infarction. Here you can see infarcted splenic tissue, but the main distinguishing feature is its location. The spleen will not be in its original location. It may be located in the pelvic region or in another location in the abdominal cavity. Aneurysm of the splenic artery will appear as a cystic structure in the hilum of the spleen. In this image we have applied color Doppler and we can see internal flow in the aneurysm of the splenic artery. Hello everyone, this is Dr. Sam and today we have small bowel ultrasound. The gastrointestinal tract has 5 distinct layers. The innermost layer is mucosa. It is hyperechoic. The second layer is the deep mucosa or muscularis mucosa. It is hypoechoic. The third thicker hyperechoic layer is submucosa, and deeper to that is muscularis propria. The fourth layer, which is hypoechoic. And finally, the outermost fifth layer is serosa. It is hyperechoic. We may not always see all 5 layers as they can be compressed by the probe or the nearby mesenteric fat, or if they are filled with fluid or intraluminal contents. Here is a water-filled stomach. The stomach and the intestines layers have the same appearance on ultrasound. Enteritis is an infection of the small bowel. On ultrasound, the bowel wall thickness will be increased due to inflammation. It will be greater than 3 millimeters. Here we have an image of small bowel obstruction. This is the normal bowel with all 5 distinct layers. The diameter will be more than 3 centimeters. We will also see the small bowel folds. They will become visible in case of obstruction, and the wall thickness may also be greater than 3 millimeters. Another feature of obstruction is the to and fro appearance of intraluminal contents. In the live video, you will see these contents moving back and forth inside the bowel in bowel obstruction. Absence of peristaltic movements may also be seen in some cases. Extraluminal fluid may also be seen in some cases of obstruction. Fluid will be visualized outside the bowel and is found between neighboring bowel loops. It is triangular in shape, and this fluid collection is called the Tenga sign. Intramural gas is another feature of obstruction. Gas is found within bowel wall. It will appear hyperechoic and has dirty posterior shadowing. Gray shadowing is seen posterior to the gas. Here is a transverse view of intramural gas. You can see it much better in this view. Gas is found within the walls, and here is the bowel lumen. This is also called pneumatosis intestinalis. Intussusception occurs when a part of the bowel is pulled into itself or into a nearby loop due to peristalsis. On ultrasound, a target sign is seen. there will be alternating hyperechoic and hypoechoic bands. The hyperechoic bands are formed by mucosa and muscularis layers. The normal submucosa is supposed to be hyperechoic, but in this case it is hypoechoic. The outermost serosal layer is very thick, and normally this layer is supposed to be hyperechoic, but here it is hypoechoic. The serosal layer appearance is easier to see as compared to the inner layers like submucosa. A pseudo-kidney sign is another feature of intussusception. You will see that the intussuscepted part of the bowel will look like a kidney in the longitudinal view. These hyperechoic areas are fat-filled mesentery, and the outer hypoechoic layer is the edematous part of the bowel. Crescent in a donut sign can be seen in transverse plane. There are alternating hyperechoic and hypoechoic bands seen on one side and a crescentic shaped hyperechoic structure made of mesenteric fat on the other side. Midgut volvulus occurs from malrotation of the bowel. It can cause obstruction and ischemia. A whirlpool sign can be seen with dilated duodenum and thickened bowel walls. Crohn's disease, which is also known as regional enteritis, is a GIT inflammation that mostly affects terminal ileum and proximal colon. These images are of ileum, and here we can see thick bowel walls. The thickness is greater than 3 millimeters. Loss of wall stratification will also be seen. We are unable to identify any layer of the bowel. This hyperechoic structure is gas, and there is some shadowing as well. Here is a transverse view showing loss of wall stratification. No layers are identified, and there is gas in the lumen of ileum. On color Doppler, excess blood flow or hyperemia is found in bowel walls. Normally, no flow will be seen in the bowel walls on color Doppler. In this image, we can see fibrofatty proliferation, which appears as a hyperechoic layer outside the bowel wall. This is due to inflammation. Limburg score is used to assess bowel vascularity with the help of Doppler ultrasound. Grade 0 is given to a normal healthy bowel. There is normal wall thickness. We can identify the layers, and there is no blood flow seen within the wall on color Doppler. In grade 1, wall thickening will be present. Due to this thickening, there is partial loss of mural stratification. No blood flow is found within the walls. Limburg score grade 2 is given when some blood flow is noted within bowel wall. It is termed hypoflow. Along with that, there is bowel wall thickening. A grade 3 Limburg score will have a large amount of vascular flow found on color Doppler. This is termed hyperflow. In a Limburg score grade 4, blood flow within mesenteric fat will be found along with bowel wall hyperemia. Hello everyone, this is Dr. Sam, and today we will study appendix ultrasound. The appendix is a tube-shaped organ in the right iliac fossa. It arises from the cecum. A normal appendix can be hard to find. The diameter must be less than 6 millimeters. Appendicitis is the inflammation of the appendix. The appendix will be dilated. The diameter will be greater than 6 millimeters and the appendiceal wall thickness will be greater than 3 millimeters. These are transverse images of the normal appendix and the inflamed appendix. You can see the increased size of the appendix here. The diameter is greater than 6 millimeters and wall thickness will exceed 3 millimeters. On color Doppler, there is increased flow noted in the appendiceal wall. Here is a longitudinal view of appendicitis. You can see a dilated appendix with increased flow on color Doppler. Spectral Doppler studies can be performed as well to help in diagnosis. The peak systolic velocity will be greater than 10 centimeters per second in appendicitis and the resistive index will be greater than 0.65. In this image, the PSV is 14.5 centimeters per second and the resistive index is 0.75. Appendicolith is a calcification located inside the appendix. It is hyperechoic and has posterior acoustic shadowing. This image shows us an appendicolith in a transverse view. It is a hyperechoic calcification with posterior shadowing. Hyperechoic periappendiceal fat is another sign of appendicitis. The appendix will be surrounded by echogenic fat. In the normal image, this fat is not prominent, whereas in appendicitis, it can be seen very clearly. Here is a transverse image showing hyperechoic periappendiceal fat. This periappendiceal hyperechoic fat structure will usually be measuring greater than 10 millimeters. It will look like a thick layer of fat surrounding the inflamed appendix. Here is a longitudinal view showing hyperechoic fat structure measuring greater than 10 millimeters. Periappendiceal fluid is another feature of appendicitis. You can see fluid surrounding the appendix. Overall, it has made the appendix hypoechoic as compared to the normal one. Here is a transverse view showing periappendiceal fluid. We can see a bit of fluid in this area. A perforated appendix can be very difficult to visualize on ultrasound. It presents with a full thickness defect in the wall of the appendix. This is the defect. Abscess is also seen outside the appendix in the right iliac fossa. This is a longitudinal view showing a defect in the appendiceal wall and abscess outside the appendix. Hello everyone, this is Dr. Sam and this video is about hernia ultrasound. The left image shows a normal anterior abdominal wall in transverse view at the epigastric region. A high-frequency linear transducer is used to scan the abdominal wall because we only need to see the superficial structures. The topmost layer is the skin. Below the skin is the subcutaneous fat layer. It is slightly hypoechoic. These two hypoechoic structures are the rectus abdominis muscles and between them is the linea alba. This hyperechoic band is the peritoneum. And over here we have an epigastric hernia. There is a small midline defect in the linea alba right here, above the umbilicus. We can see herniated fat protruding through this defect. Usually omental fat or preperitoneal fat is the herniated content in epigastric hernia. Linea semilunaris is found along the lateral edge of the rectus abdominis muscle. It is seen between the external oblique, internal oblique, transversus muscles and rectus abdominis. This is the location of the Spigelian hernia. It is a lower anterior abdominal wall hernia. The herniated contents can either be fat or bowel. Here is another image of a Spigelian hernia. We can see bowel in the hernia sac. This is the neck of the hernia sac. The defect is present here. The herniation is between the abdominal wall muscles. When imaging a normal umbilicus, we will see posterior shadowing in this area because the umbilical ring is very dense. But in an umbilical hernia, the herniated contents protrude through the umbilicus, so much of the shadowing is eliminated. Here we can see herniated fat and only a little bit of shadowing. In this umbilical hernia, we see edematous hyperechoic strangulated fat herniating through the umbilicus. Strangulated hernia contents such as fat usually appear hyperechoic. Here is another image of an umbilical hernia. This is the location of the umbilical ring and we can see the herniated contents over here. Here is a longitudinal image of the umbilicus. A hypogastric linea alba hernia is found just below the umbilicus. In this image, there is hyperechoic edematous fat, so it is a strangulated hernia. We can also see a narrow neck of the hernia sac. In a reducible hernia, the herniated contents can be pushed back through the defect to their normal positions by applying probe pressure. And these type of hernias have a wide neck. Incarcerated hernia is irreducible, meaning that the herniated contents cannot be pushed back with probe pressure. A strangulated hernia has a narrow neck, and if fat is herniated, it is usually hyperechoic. If bowel loops are involved, strangulation can cause bowel obstruction or ischemia. An incisional hernia can occur after a surgery such as a laparotomy. The hernia will occur through an incisional scar. In this image, this was the site of incision and the hernia has occurred here. Herniated fat is seen protruding through this defect. A Richter hernia is difficult to see on ultrasound. It is also called parietal hernia. In this type, only one wall of the bowel is herniated. In other words, only one side or one half of the bowel loop is herniated, while the other wall or the other half is not herniated. Here we have a normal inguinal canal image in transverse view. These three vessels are inferior epigastric vessels. These three vessels can be used as a landmark to locate the inguinal canal. This is the inguinal ligament. Over here we have a direct inguinal hernia. The hernial sac protrudes directly through the inguinal canal. We see a wide neck and hypoechoic herniated fat. Direct hernias are usually bilateral. They have a wide neck which reduces the chance of strangulation. Direct hernia is mostly found medial to inferior epigastric vessels. Here is a longitudinal image of normal inguinal canal. This is the inguinal ligament. And over here is a direct inguinal hernia. You can see an irregularity in the inguinal ligament. This is the hernia. The hernia will become more prominent with straining. Using Valsalva maneuver will provoke the hernia. The intra-abdominal pressure is increased with Valsalva maneuver, and this highlights the hernia. A hernia occurs due to increased intra-abdominal pressure caused by conditions such as weightlifting, chronic constipation, and obesity. Here is another transverse view of a normal inguinal canal. Color Doppler is applied. This right here is the inferior epigastric artery, and this is the external iliac artery. An indirect hernia is much more common than a direct hernia. In a transverse view, an indirect hernia is seen lateral to the inferior epigastric artery. Here is the neck of the hernia. The contents can be fat, bowel, or peritoneal fluid. In this case, we see hypoechoic herniated fat. This is another case of an indirect inguinal hernia. We see herniated fat lateral to the inferior epigastric vessels. This right here is the neck. A pantaloon hernia is a combination of direct and indirect hernia. The indirect hernia is seen superior and anterior to the epigastric vessel, and the direct hernia is seen inferior and posterior to the epigastric vessel. It is difficult to diagnose it on ultrasound. The epigastric vessels are seen between both hernial sacs. Amnion hernia is a rare type of inguinal hernia. An appendix is seen in the hernial sac. This is a longitudinal image of an amnion hernia. The appendix is seen in the hernial sac. This is an image of a normal scrotum, and over here we see a scrotal hernia. The herniated contents reach the scrotal sac. Using Valsalva maneuver will make the hernia more apparent, causing the herniated contents to move further into the scrotal sac. Here is an image of femoral canal in transverse view. We see the femoral artery and vein in cross section, and this is a femoral hernia. The hernial sac is found in the femoral canal. This is herniated fat. The femoral vein may be dilated. This is another case of femoral hernia. The herniated fat is found alongside femoral vein. A Valsalva maneuver can make the hernia more prominent. In this femoral hernia, peritoneal fluid is found in the hernial sac. Also, there is omental fat seen here.
Hello everyone, this is Dr. Sam, and today we will talk about kidney ultrasound. Normal and abnormal appearances. We will do a comparison between the normal and abnormal appearances. We start off with the normal views. The first one is the coronal view. We can see the left kidney and the renal parenchyma, which consists of cortex, the outer region, and the medulla, the inner hypoechoic region. But in this image it is not very clear, the medullas. And we have the hyperechoic region, which is the renal sinus fat. Because it has fat, it is more dense and it appears hyperechoic. And below we can also see the renal pelvis, but we cannot see the ureter because normally we do not really see the ureters. And in the longitudinal view we have the liver, the right kidney. Above that is the liver, and we can appreciate the kidney. It has the outer cortex and the renal sinus, which are very well visualized in this picture. Next view is the transverse view. It is a cross-sectional image of the kidney, And here we can see in this right image we can see it more clearly. We have the cortex and the renal sinus very well visualized, and above them is the liver. And here we can see some of the renal pyramids, and we can also see the renal pelvis. The first case is the renal cyst. This is a simple renal cyst. It is located in this region. We can see it's very round and it will have posterior acoustic enhancement. This is a typical feature of a cyst. It will be round, it is anechoic, and it will have enhancement. And this is another appearance in the longitudinal view. It is more detailed, and you can see the cyst is in the upper pole of the kidney, right kidney, upper pole. This is again the acoustic enhancement which is behind the cyst. It will be a hyperechoic region because more ultrasound rays are passing through the cyst, so it gives enhancement. In polycystic kidney disease, we have multiple cysts, round anechoic structures with posterior acoustic enhancement. There will be multiple of them. There is one in the cortex. We can see in the transverse view, this is the renal parenchyma. Most of them are near the renal sinus or the medullary region, and there will be more than one. It is an inherited disorder. The longitudinal view of the right kidney, and there are multiple cysts again with posterior acoustic enhancement and anechoic round structures. Now this is the longitudinal view of a renal stone. In this you can see there is a stone lodged in the kidney and it has shadowing. It is followed by a stream of dark regions, and this is the whole kidney, and we have shadowing behind the hyperechoic stone. And we have another image in the transverse view, a hyperechoic stone followed by a dark area with acoustic shadowing, always behind the stone. Staghorn calculi are large calculi which involve the renal pelvis and at least two calyces of the kidney. This has heavier shadowing, but this is just a transverse view, so we cannot appreciate it as well as the one in the longitudinal view. We can see multiple stones, which is involving a much larger region as compared to the solitary stone we saw earlier, and we can see one shadow, acoustic shadowing here, and another one acoustic shadowing here behind the stone. Pyelonephritis is the infection of the kidney, and it usually involves the renal pelvis and the renal parenchyma, and it can cause abnormal echogenicity in the kidneys. The regions that are hyperechoic, they are due to hemorrhage, and the regions that are hypoechoic, they are due to edema. The transverse view of pyelonephritis shows us the hyperechoic area and some hypoechoic area. It is overall heterogeneous appearance. We have to correlate these clinically as well. Another longitudinal view which shows us the medulla as well very clearly, and we can see the abnormal echogenicity, the hyperechoic regions. Nephrocalcinosis is a condition in which calcium is deposited in renal parenchyma. Most common location is the medulla, and we can see the hyperechoic regions. These are the calcium deposits throughout the medullary regions. The density of the calcifications is more in this image, that's why it leads to shadowing, posterior acoustic shadowing. Here's another one over here, and this one is also in the medullary region. It has occupied the medullary pyramids. The chronic kidney disease also causes increased echogenicity of the kidney along with some poor visualization of structures such as the medullary pyramids. We do not see them very clearly in this image. Now we study the grading of cortical echogenicity. Now the normal one will always be the renal echogenicity, that will be less than the liver echogenicity. As we can see here, the cortex is hypoechoic as compared to the liver. Now on the right side, this is grade 1 echogenicity. We can see the liver parenchyma and the cortex of the kidney, they have similar echogenicity, they are matching. In grade 2 echogenicity, the renal echogenicity is more than the liver. In renal failure, the kidney is very hyperechoic and it is also reduced in size. This one we can see is almost 6 centimeters only, whereas the normal size range is above 9 centimeters. Angiomyolipoma is a benign renal tumor which consists of vascular, smooth muscle and fat tissues. It is usually a round mass which is somewhat hyperechoic. Another longitudinal view of the kidney showing angiomyolipoma. Here we can see the rounded hyperechoic mass in the lower pole of the kidney. Wilms tumor is a rare kidney tumor that occurs in children. Here we can see a large heterogeneous mass located in the upper pole of the kidney. Renal cell carcinoma is a malignant condition of the kidney. Here we can see a heterogeneous mass in the upper pole of the right kidney in the longitudinal view. Renal cell carcinoma in transverse view. The heterogeneous mass can be seen here, occupying the cortical and medullary regions. Metastatic lesions usually appear as heterogeneous masses in the organs. Another heterogeneous appearance we can see in the lower pole of the kidney. This is also a longitudinal view. Sickle cell anemia can also cause hyperechoic kidney or echogenic kidneys, usually the medullary regions. As we can see in this image, the medullary regions are echogenic. This can lead to kidney injury and chronic kidney disease. Cross-fuse ectopia is a condition in which both kidneys are found fused together. Here we can see the two separate renal sinuses and also this groove here that separates both the kidneys, and this is on the left side. The right side in this case will be empty, it will not have any kidney. Cross-fuse ectopia in the longitudinal plane, we see two separate sinuses again more clearly. In renal trauma, the hyperechoic and heterogeneous areas are due to the hemorrhage and hematoma. In this image, we see the proximal ureter that is somewhat dilated because of the presence of a stone, and it is causing the dilation of the renal pelvis as well. In grade 1 hydronephrosis, the renal pelvis is dilated, but the renal calyces are not dilated. In grade 2 hydronephrosis, both the renal pelvis and the renal calyces are dilated. In hydronephrosis grade 3, both the renal pelvis and calyces are dilated, but to a greater degree as compared to grade 2 hydronephrosis, and we can also see some cortical thinning. Grade 4 hydronephrosis shows a very large degree of dilatation involving the entire kidney, and there is also a higher degree of cortical thinning, and it is leading to
renal atrophy. These are normal views of a dilated bladder. This is the longitudinal view, and here is the transverse view of the dilated bladder. Cystitis is the inflammation of the bladder. In this image, we can notice that the bladder wall is thickened. Now, if there is cystitis, the wall thickness of the bladder must be more than 5 millimeters. A stone in the bladder with posterior shadowing. The stone is appearing hyperechoic. Bladder debris appearing as hyperechoic area, along with some heterogeneous areas in the bladder which would normally appear anechoic if it is only filled with urine. Usually this is due to bladder injury, hematuria, or any injury to the urinary tract. Bladder cancer, usually called transitional cell carcinoma, appears as a rounded, heterogeneous or round hypoechoic mass originating from the wall of the bladder. Hello everyone, this is Dr. Sam, and today we will study prostate ultrasound. Here we have transabdominal images of the prostate in transverse and longitudinal planes. The normal dimensions are 3 into 4 into 2 centimeters, and the normal volume shouldn't be more than 30 milliliters. The prostate is best seen with a transrectal approach. These images are transrectal images of the prostate. We can see some zonal anatomy. Here is the peripheral zone, and this is the transition zone. The peripheral zone is hyperechoic than the transition zone. This hypoechoic channel leading towards the bladder is the prostatic urethra. Most of the tumors and cancers occur in the peripheral zone, and benign prostatic hypertrophy mostly occurs in the transition zone. Calcifications in the prostate appear hyperechoic and may have posterior acoustic shadowing if the calcifications are large enough. Benign prostatic hyperplasia is an abnormal enlargement of the prostate. The prostate volume will be greater than 30 milliliters. We can see an enlarged prostate here. In a transrectal view, we can see more detail. BPH occurs in the transition zone, and we can see compression of the peripheral zone by the transition zone. Benign prostatic hyperplasia can lead to intravesical prostatic protrusion. It is the enlargement of the prostate towards the bladder floor. This imaginary line is the boundary between the bladder and the prostate, and here is the protruding prostate. Grade 1 protrusion will measure 5 millimeters or less. Here we have grade 2 intravesical prostatic protrusion. The prostate protrusion is increased here, measuring between 5.1 to 10 millimeters. In grade 3 intravesical prostatic protrusion, the value will be more than 10 millimeters. Now we have transabdominal approach with longitudinal views here. This is the imaginary line for easier understanding of protrusion. The grading is similar. It is a grade 1 IPP measuring less than 5 millimeters. This image shows a grade 2 IPP measuring between 5.1 to 10 millimeters. Here we can see a very large prostate. The IPP is greater than 10 millimeters. This image is in transverse view. Here is the bladder and this is the prostate. Grade 1 protrusion is very subtle. It is less than 5 millimeters. Moving on to grade 2 IPP, you can see a larger prostate gland as compared to the previous one. And finally, a grade 3 IPP. The protrusion is very large. It is greater than 10 millimeters. Prostate cancers mostly occur in the peripheral zone. They usually appear hypoechoic, but in some cases can appear isoechoic or hyperechoic. And on color Doppler, we will see internal vascularity. Here we will see Doppler signals inside the masses. Here is another image of prostate cancer. A hyperechoic mass is seen in the peripheral zone. Prostatitis is the inflammation of the prostate. The appearance may mimic prostate cancer because it also contains focal hypoechoic areas, but the peripheral zone is mostly clear here. On color Doppler, increased vascularity is noted, suggesting inflammation of the prostate. Prostatitis can lead to an abscess, which will appear as ill-defined hypoechoic or heterogeneous area. The prostate will be enlarged. There will be no internal flow on Doppler. However, there will be increased flow in the periphery of the abscess. Utricle cyst is a focal dilatation inside the prostate. It will appear as an anechoic cyst. Here we have a transrectal view showing a cyst. It is anechoic and has posterior enhancement. Thank you so much for watching. Please subscribe and stay tuned for more imaging videos.